Hello, everyone. I'm Kimberly Ram, Senior Manager for Policy and Advocacy here at HFA. Thank you for joining us in today's session entitled Making Medicare Work for You. We have an excellent speaker who will provide you with a wealth of knowledge as you navigate the healthcare system. Ms. Kathleen Holt currently serves as Associate Director of the Center for Medicare Advocacy. She has an extensive background, having served in many areas of the healthcare industry, from health insurance to various hospitals, to serving as Special Assistant United States Attorney for the U.S. Department of Health and Human Services in Seattle, Washington. She even created her own Seattle area law practice to advocate for the needs of older and disabled individuals. It's very clear Ms. Holt has a genuine passion for patient advocacy, and we are delighted to have her join us today. Without further ado, I present to you Ms. Kathleen Holt.
Thank you, Kimberly, and I'm delighted to be with you today. Today we're going to talk about making Medicare work for you and an overview of Medicare for the Hemophilia Federation of America. Just a little bit about the Center for Medicare Advocacy. We are a national nonprofit law organization founded more than 30 years ago, and we work to advance access to comprehensive Medicare and quality health care. We're headquartered in Connecticut and Washington, D.C., staffed by attorneys, advocates, nurses, and technical experts. We help educate, provide legal analysis, writing, and assistance to Medicare beneficiaries. We work for systemic change in policy and litigation based on our experience with the problems of real people. We do Medicare appeals, and we also work on Medicare, Medicaid, third-party liability insurance projects. So in today's program, I just want to go through our agenda, the Medicare overview of eligibility, enrollment, payment, and coverage. So first, we'll give an overview of Medicare from the 10,000-foot level. Then we'll look at the eligibility for Medicare, the enrollment process, coordinating Medicare with other insurance, costs and assistance to help individuals pay for Medicare, choosing between Medicare, traditional Medicare, and a Medicare Advantage plan, the private plans, and also provide you with some additional Medicare resources for people who are living with hemophilia. So turning to our part one, an overview of Medicare. Medicare in summary. Medicare is a national health insurance program started in 1965. People usually qualify for Medicare based on paying into Social Security, not based on their income. Unlike Medicaid, Medicaid is a state and federal partnership, whereas Medicare is a federal program. Medicaid is based on income. Medicare is based on paying into the Medicare system. Medicare covers people who are 65 and over, certain people with disabilities, which I will speak about further, and people with end-stage renal disease. Medicare covers hospitals, nursing home, home health, doctors, durable medical equipment, prosthetics, orthotics, and supplies, hospice, prescription medication, some preventive services, and vaccines. People can get Medicare through private Medicare Advantage plans, which I'll again speak about further. But Medicare Advantage plans are required to cover at least as much as traditional Medicare covers and follow the same coverage rules. Medicare is an insurance model, which means that Medicare covers some of the cost of some health care. And these are the general parameters for Medicare. When care is reasonable and necessary for an illness or an injury, to diagnose, treat, or rehabilitate a person, with limited preventive coverage, and there are copays, deductibles, and premiums. There are 4 parts to Medicare. Don't think that these are parts of a whole. These are parts that are different ways, if you will, to get Medicare. There's the traditional Medicare, the program that I mentioned that started in 1965. These are Part A essentially inpatient insurance costs, not always, but generally. And Part B, Medicare, which is outpatient medical insurance. Then there is privatized Medicare. Part C joined the Medicare family, if you will, in the 1990s. Medicare Advantage plans came into the picture, offered by private insurance companies. And then in 2006, Medicare added Part D, or the prescription drug plans. Again, looking a little more closely at those four parts of Medicare, traditional Medicare, Part A and Part B, make up a segment of Medicare that people can elect when they initially become eligible for Medicare or during open enrollment period every year. This traditional Medicare typically includes Part A and Part B of Medicare, and then an individual can also get a supplemental policy, or what's typically known as a Medigap policy, to cover the gaps in traditional Medicare, those coinsurance and deductibles that I spoke of. Those gaps can also be covered if an individual has a retirement plan, for instance, through a company they used to work for, that will help to pay those coinsurances and deductibles. There's also government assistance available to pay for coinsurance and deductibles, and I'll talk about that as well. And then the other option, if you will, to traditional Medicare is the Medicare Advantage program, those private insurance companies. Medicare Advantage plans come both included with prescription drug coverage or as standalone Medicare Advantage plans. And then there are the standalone prescription drug programs. The prescription drug programs that are private insurance that help individuals pay for prescriptions that are not covered under Medicare Part A and Part B. I would note, and I'll talk about this further as well, that folks with hemophilia, those clotting factor medications are typically covered under Part B Medicare, B as in boy, not D. And CMS is the acronym for the Centers for Medicare and Medicaid Services that oversee the entire Medicare program. So Medicare coverage for Parts A and B, again, include Part A. As I mentioned, it's mostly inpatient, but you'll see there are some other coverage here for home health and hospice, but also hospital and skilled nursing facility. And then the Part B services, the medical services, physician services, Part B drugs, as I mentioned with the clotting factor, durable medical equipment and supplies, ambulance, therapy, and observation status. So let's look a little closer at those private Medicare Advantage plans. Again, Medicare Advantage plans are just another way to get Medicare benefits. And when people get Medicare, they have to choose, do you want traditional Medicare or do you want a Medicare Advantage plan? Medicare Advantage plans contract with CMS to administer Medicare, so they are overseen by the Medicare program. Medicare Advantage plans combine Part A and Part B coverage most of the time. There are additional services that are offered, and Part D, prescription drug coverage. Medicare Advantage plans have essentially the same coverage rules as traditional Medicare, and those additional benefits may include something like dental, vision, hearing, some other types of benefits that are not offered in the traditional Medicare program. One has to look specifically at the value of those extra benefits that are available in Medicare Advantage and the trade-offs, and we'll do that a little later in the program. Medicare Advantage plans are not supplemental insurance. These Medicare Advantage plans are not in addition to or on top of regular Medicare. They are a choice that a person makes between taking private Medicare or the public benefit, the traditional Medicare. There are no Medigap policies that are allowed with Medicare Advantage plans. So if you have deductibles and coinsurance on a Medicare Advantage plan, you typically have to cover those yourself unless you have retiree insurance, VA coverage, or some other type of insurance that we'll look at in a little while. Again, the deductibles, copayments, and coinsurance are generally paid out of pocket in these private Medicare Advantage plans. So now let's turn to specifically how someone becomes eligible for Medicare. When someone ages into Medicare at age 65, that's the usual way that people become eligible for Medicare. There are other ways that people can become eligible for Medicare. When someone under age 65 meets the medical criteria for Social Security disability insurance or railroad disability and satisfies a waiting period, or when someone has end-stage renal disease. So when it's due to disability becoming eligible for Medicare, the individual has been determined under Social Security or Railroad Retirement Act to meet the medical criteria for those programs, Social Security disability insurance or railroad disability benefits, based on their work record. And generally, when an individual has fulfilled a 29-month waiting period, that doesn't include a partial month, beginning from the Social Security Association determined onset date of the disability, the individual is no longer performing substantial gainful activity. So here's an example of that waiting period. Mr. Hall applies for disability. Social Security determines the onset date of the disability, the date he was no longer performing substantial gainful work activities, to be June 10th of 2019. Mr. Hall's waiting period for Social Security is 5 full months after the first of the month in which Social Security determined his onset date. So in this case, those 5 months would include July, August, September, October, and November, bringing us to December 1st, 2019. And then Medicare starts 24 months from that point. So that's where the 29 months come in. It's very difficult. As an organization that works a lot on policy, we are trying very hard to shorten the amount of waiting period that's necessary in order for someone who is disabled to become eligible for Medicare. Here are some examples of other folks who are eligible for Medicare but not insured for Social Security. There are some public employees, fire people, police people, teachers who only pay Medicare taxes but not Social Security. And also disabled widows or widowers who are over the age of 50 can qualify on the Social Security record of their deceased spouse. What is the enrollment process for Medicare? So again, for folks who age into Medicare, they are already receiving Social Security benefits. Then that individual will be automatically enrolled in Medicare Parts A and B with the option of turning down Part B, since he or she must pay a premium for Part B. Typically, there's no premium paid for Medicare Part A, and I'll discuss that a little further when we talk about payments for Medicare. But on this, I really want to emphasize the fact that everyone has to be enrolled in Medicare Part A and B, and then individuals get to make a choice whether or not they are going to take all of their benefits through Part A and B, or if they're going to take the private Medicare insurance, Part C. We'll look at that a little further as well. If someone is not yet receiving Social Security benefits when they become eligible for Medicare, the individual has to actively apply for Medicare. And they apply at socialsecurity.gov. So while Medicare and Social Security are different programs, Social Security handles all of the eligibility and enrollment into Medicare. There's a full brochure at the link that I've provided on the slide that talks about applying for Medicare online. The initial enrollment period for Medicare is 7 months when someone is aging into Medicare at age 65. Those 7 months are the months, I usually refer to it as the months that hug the birthday month. So 3 months before someone turns 65, the month of the 65th birthday, and 3 months after. And if you sign up, for instance, you'll see on the bottom of this chart, 3 months after you turn 65, if you wait to sign up for Medicare, the longer that you wait, then the longer it takes you actually have this slightly built-in waiting period. I will say at this point, because I think it's really important to note, that you can delay enrolling into Medicare if you have other coverage. And we'll look at exactly what is allowed to delay getting into Medicare. So if someone is under the age of 65 and they're determined to be disabled by Social Security, that individual will be contacted by mail by Social Security to inform them about their Medicare enrollment after they meet that 29-month waiting period. Again, the default is automatic enrollment in Medicare Parts A and B with the option of turning down Part B if you have other types of coverage. The largest reason that an individual may want to turn down Part B, again, is because they have coverage through someone's active employment, either their own or a family member, not retirement employment, but active employment. If an individual declines Medicare Part B, fails to enroll timely, it may result in a Part B late enrollment penalty, which is 10% for every 12 months they are not enrolled. The general enrollment period for someone who misses their 7-month window to sign up for Medicare is January 1st to March 31st of every year for coverage that doesn't start until July of that year. So missing that 7-month initial enrollment period for Medicare may cause someone not only to have a penalty for late enrollment, but it may also cause a person to be delayed in enrolling in Medicare. If the late enrollment penalty is incurred by someone who is under the age of 65, it will be vacated when the individual turns 65, and the individual will get a new enrollment period with no penalty. So how does Medicare coordinate with other types of insurance? This is a slide that will give you an idea of how you need to coordinate other types of insurance with Medicare. There's a telephone number on this slide to confirm that information of other insurance with the coordination benefits recovery center. There's a telephone number there. I would encourage anyone who has additional coverage to coordinate with Medicare to make sure everyone knows what every type of insurance is. That includes informing doctors, all the providers that an individual sees, so that those providers know exactly who to bill first, and that saves a lot of trouble on the back end. All of this it can be accomplished as well through the initial enrollment questionnaire that a person fills out at enrollment to include that information, but it's always good to confirm it with this Benefits Coordination and Recovery Center. In the event that someone has an injury, either a personal injury, a workers' comp, they're waiting for a settlement, Medicare will make a conditional payment. And what that means is rather than having the providers wait for the settlement to occur, which sometimes could take years, Medicare will conditionally pay first and then expect to be reimbursed when that settlement happens. So generally speaking, when Medicare is the first payer, meaning in a line of multiple payers, when Medicare pays first, according to the payer rules, the individual must not delay in signing up for Medicare in a timely way, either because of disability or because they're aging into Medicare. You still have to sign up in a timely way if Medicare is going to be the first payer. Generally, when Medicare is not the first payer, the individual may delay signing up for Medicare. So who pays first? These are some general rules about payments. If someone is eligible for both Medicare and Medicaid, then Medicare pays first. Medicaid is always the payer of last resort. If an individual is age 65 and over, covered by a group health plan, for a group with 20 or more employees, meaning a larger organization, 20 or more employees, the group health plan is the first payer, and Medicare is in the second payer place. I'm not going to go through all of the information on this slide. I would say to you, please use this as a resource so that you have a sense. You can apply your own life circumstance to these rules if you have additional insurance, but know that there are specific rules with Medicare about who pays first, and given that, there are specific rules about being able to delay enrolling in Medicare. Just a few notes about insurance, such as through the COBRA plan, which is a continuation of benefits. If someone has had insurance through an employer or through their spouses or family employer, through the Veterans Administration, and through TRICARE for Life, which is the military insurance. If someone is disabled and they're covered by COBRA, so they have elected to continue their employer insurance, Medicare pays first and COBRA pays second. So again, that's important because even though you have COBRA and you think it's very robust insurance, you cannot delay signing up for Medicare or you will receive a penalty. A veteran with veterans benefits, so the VA and Medicare coordinate with one another, depends on where the individual is getting care. If they're getting care through the VA system, the VA will pay first. If they're getting care in the community, Medicare will pay first. And TRICARE for Life, again, when care is provided in military hospitals and by federal providers, TRICARE pays first. Otherwise, in the community, Medicare pays first. Again, I can't emphasize enough about COBRA because these are the largest problems we see with people who end up having a lifetime Medicare premium penalty because they don't understand the COBRA rules. It's confusing, and again, something we're working on to try to make it less confusing because people often get caught in the trap where it's inadvertent and they think they have coverage that should suffice and not sign up for Medicare. But the caution around COBRA is if an individual loses an employer coverage, and again, it can be their own coverage or coverage of a family member, and that individual has Medicare eligibility, he or she should be aware of the COBRA election period, the Part B enrollment period, which again, I've described how long that enrollment period is, and the Medigap open enrollment period for Supplement. All of those have different deadlines and they overlap. And what an individual decides about one type of coverage may cause them to lose their rights under other types of coverage. Again, if someone has COBRA or they're contemplating using COBRA, it's important to talk to the Human Resources Department of the employer to make sure that you're making the appropriate choice. So now let's look at costs and assistance to help pay for Medicare. I described the Part A and Part B Medicare and why the Medicare Part A is sometimes known as premium free. More than 90% of Medicare beneficiaries don't pay for Part A. That's a misnomer, frankly, because you have paid all of your life if you've paid into Medicare, or if you are receiving benefits based on a parent who had paid into Medicare, then that's why the premiums are noted to be free, because we paid into the system all of our lives. And once someone has earned 40 Medicare quarters of coverage, and there are 4 quarters in a year, so the equivalent of 10 years of working over a lifetime, then an individual has eligibility either through their own record or, as I mentioned, through a parent record or a spouse, eligibility for premium-free Medicare Part A, and may elect Part B benefits. So for Part B, most people do pay $144.60. That's the 2020 amount, the premium, a monthly premium for Medicare Part B benefits. The premium for the Medicare Advantage plans, the private Medicare Part C, are determined by those private Medicare Advantage plans. And the premiums for prescription drug plan are also determined by the private prescription drug plan. But those are the premiums for Medicare. There's help if someone has a lower income. They should look into the Medicare savings programs. Medicare savings programs are help from the states to provide assistance with meeting some or all of the Medicare premiums, the deductibles, co-payments, and co-insurance. Often, the Medicare savings programs are based on the amount of the federal poverty level, which updates each April. States, territories, and Washington, D.C. may alter Medicare savings program requirements. For instance, Connecticut eliminated resource or asset tests. Approximately a third of all states don't have any asset tests for getting assistance through the Medicare savings program. Washington, D.C. raised the income eligibility from one of the Medicare savings programs from 100% to 300% of federal poverty level. You'll see many states have increased the eligibility, the federal poverty level, I should say, making it a lot easier for individuals to apply and obtain assistance through these programs. I've included here a link to an eligibility chart by state to help determine if you may qualify for assistance. I think people who have a significant amount of resources, if not income, have been surprised by the amount of assistance that they can get if they look into these programs. So I would encourage that. There's something called the Low Income Subsidy, or LIS. And this is for help paying for most or all or most of Part D prescription drug medications. And LIS is automatic if someone also has Medicaid or a Medicare savings program eligibility. So again, there are other ways to also qualify for what's also known as extra help. And I would encourage you again through this link on this slide to look at the LIS eligibility chart by state to determine if you may qualify for assistance with payment of medication. There are some other payment resources, the Medicare Savings Program Part A and Part B buy-ins. So what this is if someone didn't pay into Medicare, they didn't qualify. We know a number of individuals worked under the table, or they didn't pay into Medicare, or they didn't pay into Social Security for some reason or another. And rather than the states bearing the cost of insurance, the states will buy into Medicare for those individuals. And some of these do include retroactive coverage as well. I would encourage everyone, there's something called the state health insurance programs. There is one in every state, and these programs exist with people who are well-trained in Medicare to help with individual counseling. And I don't mean counseling like necessarily getting into your business, as much as just looking at the circumstances of your Medicare and being able to help guide you with regard to appropriate choices for Medicare, knowing when to apply, knowing when you're eligible, knowing when to enroll, knowing which Medicare Advantage plan to choose or Medigap plan to use for those gaps, or whether or not you would be better off in traditional Medicare. Those state health insurance programs are free. They, again, exist to help people with Medicare, and we find them to be incredibly helpful for individuals. So now I want to look at choosing between traditional Medicare and Medicare Advantage. This is the choice that people have to make when they first become eligible for Medicare, and also every year during the annual open enrollment period between October 15th and December 7th, when you make your choice for the Medicare plan that you would like to have for the next year. It's important to know what to look for, to know what to ask yourself. And I want to go through that. We created what we call a roadmap, but we want to help people to be better informed, to feel more confident about how to narrow the options out there. There are some counties in the US that have hundreds of Medicare Advantage plans available to them. And it can be overwhelming. Even if you have 20 Medicare Advantage plans available to you, it can be overwhelming. And if you are eligible for Medicare, you probably get a lot of mailings every year, or you see a lot of commercials, or there's a lot of money to be made in Medicare. So it's a very competitive marketing field. You need to ask yourself the questions that you want to know in order to make an appropriate decision. So I have 10 questions on this list. Do you qualify for payment assistance, or do you have access to other coverage? So again, we talked about the Medicare Savings Program. That's the payment assistance program that can help people, as well as the Low Income Subsidy Program. And again, every state is different. So some people may look at that and say, well, I don't know if I qualify. Well, the only way that you can find out is to look into the program. I will also say that the applications for these programs are really quite simple in compared to applying for disability or applying some of these other applications. The Medicare Savings Program, low income subsidy applications usually take folks about 15 minutes to complete. So again, encourage you to look into that. Do you have employer or military or other insurance? And what is the Medigap availability? So those are remember the Medigaps are the supplement plans that help pay for the coinsurance and deductibles. Which providers or facilities do you go to? So it's important as you think about providers and going to see them, if you have people that you really depend on, that you're very loyal to, that you would want to make sure that they are either in a Medicare network, as Medicare Advantage plans have networks. How important is it for you to continue seeing those providers? Do they accept Medicare? And what Medicare Advantage networks do they participate in? So you can start to narrow the options of what Medicare Advantage plans are available to you if you feel that you want to stick with the doctors that you have, that you just don't want to take whatever's in a plan's network. So sometimes it's important to go to the doctor's office or call the doctor's office and speak to the front office staff and say, what Medicare Advantage plans do you participate in? And will you be participating in next year, so that you can also get that information from that provider. Which medications do you take? Again, we know in the network that I shouldn't use the word network, but in the world of hemophilia, there are certain medications that are critical. And are those medications, if they're covered under Medicare Part B, as in boy, Medicare, then you should be okay. I shouldn't say okay. You should be able to get those medications either under a Medicare Advantage plan or Medicare, traditional Medicare. If you are receiving other medications, then you would typically get most medications through Part D, as in dog, Medicare. And those medications are on formularies. And so you will check with the Part D plan to see if the medications that you take are under those formularies. And sometimes the formularies will only offer generics. So again, ask yourself the question, can I take generics? Now, having kind of walked you through the first three questions here, I will say that these are all, well, it's good for you to be thinking about these. These are also kind of a screening, these are screening tools that we've developed, but these are also the types of questions that you might expect if you call those state health insurance programs, or SHIPs as they're called, to help you with that individual counseling about which Medicare plans to take. Do you want your care choices to be managed? So you can choose all your own doctors under traditional Medicare. All doctors, all providers, all hospitals, all therapists are enrolled in, they're not all enrolled, but the ones in Medicare, you can go see most people who take Medicare if you're in traditional Medicare as opposed to a network. Do you have to obtain a referral to see a specialist? A number of Medicare Advantage plans require that you have to go see your primary care provider in order to see a specialist. Do you have to get authorization for some services? So again, some Medicare Advantage plans are very strict on obtaining prior authorization before you are able to obtain any services, and you're penalized if you don't get that prior authorization. Another important question, do you travel outside your general home area? So the reason for that question is that most Medicare Advantage plan networks are by county or at the most by state. And so the issue with traveling is, for instance, if you're in one state, you go see a relative in a different state and something happens, you can get emergency care, but you can't get care beyond that typically. There are some Medicare Advantage plans that are understanding how limiting this network problem is, and they are creating a product called passports that will allow the plan to expand to additional providers in additional states, but that it's rather clunky still, and there's not a lot of that. So just look at whether or not you're on the road, and if you are outside your network, your home network, you may have limitations, and that would be an issue to think about. How important are annual maximum out-of-pocket costs? Now, one of the things that I didn't mention before that I will now is that I did mention that Medicare Advantage plans cannot have a Medigap supplement plan to help pay for coinsurance and deductibles. But most Medicare Advantage plans do have something called a maximum out-of-pocket. So the current maximum out-of-pocket is $6,700 a year. And some Medicare Advantage plans may lower that maximum out-of-pocket for more first dollar cost sharing. And let me explain what that means. They may say, oh, the hospital deductible is typically $1,400. Well, we're going to make the hospital deductible $2,000, but we'll lower the maximum out-of-pocket. So there are trade-offs with how different Advantage plans manage. It's complicated, and it's exponentially complicated because there are, I believe, 4,300 Medicare Advantage plans that are available in the United States. So what is the value of other possible services? So one of the draws and one of the things we see a lot of commercials on are plans that say, you know, you can get extra, you can get dental, you can get vision coverage, you can get hearing aids, you can get home health aids, you can get other types of services, meals, for instance. That's another one that's been we've seen quite a bit lately. The issue with those is that they're usually limited in value. So it may be, it's not comprehensive dental. You may be able to get a cleaning or two a year, or you may be able to get $100 worth of dental or $200 toward a hearing aid. You want to see, when you look at your choices, what the value of those extras is. Silver Sneakers has become a really popular benefit in Medicare Advantage plans that pay for gyms. And it's important to know, like, are you going to use these benefits, and what value do these benefits have for you? How do you weigh the convenience of one-stop shopping? Well, what is one-stop shopping? That is a Medicare Advantage plan that includes a prescription drug benefit. So you make one choice, and that one choice is, I'm going to just sign up for this Medicare Advantage plan. They're going to cover my drugs. Everything is all included, as opposed to traditional Medicare, where people typically choose Medicare Part A and B, and then they also choose a Medigap plan, which will cover the coinsurance and deductibles, and then they also choose a separate prescription. You're constantly having to check, is my doctor in the network? Network, have any of my doctors left the network, keep up with all it. So if you go to a doctor and the doctor says, okay, I'm going to document that this test is reasonable and necessary for you to have, or this injection or this medication, and the doctor tells Medicare why it's reasonable and necessary, and Medicare typically, for the doctor, you're the treating doctor, you make that determination. Okay, so that's one scenario. Another scenario is someone is in a Medicare Advantage plan. The treating doctor says, I think you need this test, this injection, whatever it may be. And the Medicare Advantage plan may say, whoa, let us take our utilization review committee and our medical director, and we will sit here and second guess whether or not you should be getting that procedure. And so we see a much higher level of denials under the Medicare Advantage plan than we do under traditional Medicare. It's something else to think about. Some people, it doesn't bother them at all that there's another layer of decision making that happens in their Medicare Advantage plan, but it's an important distinction for people to know about, that between prior authorization and utilization and review management and kind of the extra determination. Some of the Medicare Advantage plans can be pretty aggressive about denying coverage. So we want to make sure that people understand that that's something to think about. Statistically, only about 1 to 3% of individuals who are denied by a Medicare Advantage plan choose to appeal. I want to emphasize the fact that if you are in a situation where a Medicare Advantage plan has denied a service that you believe that you should have, Statistically, if someone challenges that denial, 75% of the time on the initial denial, that denial is overturned. Really important to know, because again, the denials can be numerous with Medicare Advantage plans. Will you be more likely to seek care for yourself? If it's convenient, meaning there's a large number of providers and suppliers that you want to go to, they're available to you. Is the cost prohibitive to you so that it limits the amount of choices that you have? And frankly, when you put everything together, the cost of a Medicare Advantage plan can be lower than the cost of traditional Medicare. Or is access to care easier? Is that of high value to you? So these are the 10 kind of questions to think about when you're looking at how to make a choice with traditional Medicare or Medicare Advantage plan. Just a few other things about that. Remember, as I said, there is provider and supplier networks are vast with traditional Medicare, and coverage is not limited when you're within the United States and territories. So you could live in Maine and go to a doctor in California, and it's just the same thing. Doesn't matter where you are within the United States. And then if you're thinking about getting a Medigap plan to cover the gaps that Medicare doesn't cover, those co-insurance and deductibles, you need to, and every state has an insurance commissioner that typically on their website lists the Medigap plans that are available. Are there guaranteed issue rights in your state? There's a federal law that says everyone over 65 or over has a guarantee to a Medigap plan in the first 6 months that they sign up for Medicare. So that's something to look at. Other states continue that forever. Other states have things like where it's community rated, so it doesn't matter if you're 45 or you're 95, the price is the same of the Medigap plan. Some of the Medigap plans do have a pre-existing condition requirement. Those may be anywhere from 1 to 6 months where they won't pay when you first join the Medicare Medigap plan. But remember, this is just for coverage of the gaps, the coinsurances and the deductibles, which in Medicare Part B may be as high as 20%. Can you afford the premiums of the Medigap plan? Again, it's important to look at what those plan premiums are. Typically, they run anywhere from $45 a month up into well, exorbitant amounts, but there are different levels of premiums, and every plan offers the same type of benefits. So not to confuse things, because we have already talked about parts of Medicare, but there are plans in the Medigap plans that are Plan A is the same. Every Plan A is the same across the country. Plan B, every Plan B is the same across the country. So you always look for the least expensive plan in your state. And do you have other options for cost sharing? Again, think about whether or not you have employer insurance, retiree insurance, VA insurance, TRICARE, anything else that could help to pay for the cost sharing. And some people, 21% of people on Medicare don't have any supplement. They decide that they're going to kind of cross their fingers and pay the coinsurances and deductibles as they come up. Medigaps, again, are typically not allowed with Medicare Advantage plans. So if you have a Medicare Advantage plan, you will have that maximum out of pocket, and that will give you some level of security. There is a coordination with other types of coverage can be complicated if somebody has a Medicare Advantage plan, so that coordination can be difficult. There's something to watch out for that's called seamless conversion enrollment. And so if you're retiring from an employer and you have, say, Aetna, then Aetna may roll you over at age 65 or at retirement into an Aetna Medicare Advantage plan. They're not supposed to do that, but as we are speaking, they're making it more easier. The administration is for, excuse me, I'm so sorry, for people to be able to do that. I'm going to take a little bit of water. Plan networks may not always have adequate specialists or other providers to serve the patient needs. So by this, I say make sure that there's network adequacy, particularly if you need a specialist. That the Medicare Advantage plans are required to have networks that are adequate to serve all types of needs. Network providers may choose to join or leave a network at any time. And plans can terminate providers at any time. So again, this is what I had mentioned before. While you choose a plan for a year and you're locked in and you can't move, contracts between Medicare Advantage plans and providers happen on a rolling basis. There's something called a special enrollment plan that I didn't get into a lot, but again, it's important if you are late to Medicare. You could be late because, as I mentioned, if your employer-based insurance coverage is in primary position, that when the active employment of someone ends, then that means that there's a special enrollment plan for someone to get into Medicare. There's also a special enrollment plan, a special enrollment period, I should say, for people who are duly eligible and those who are eligible for Medicare savings plans and low-income subsidy. Other thoughts about Medicare Advantage plans. You should look at Medicare Advantage plans by the model of plan that they are. So if something is a health maintenance organization or an HMO, those plans usually have no out-of-network coverage, and they require someone to go through a primary care provider. The preferred provider model of Medicare Advantage plans usually have out-of-network coverage, but it's at higher cost to the beneficiary. And if you look at the options of HMOs and PPOs, one of the things you'll see is that HMOs are typically lower priced, and that's because those networks have more control over whether or not an individual is going to someone in their network, whether or not an individual is receiving care through an authorized care. They have to go through a prior authorization process. So the management of HMOs is much more stringent than the PPO model, which typically a person doesn't have to go through a gatekeeper provider in order to go to a specialist, and they can go out of network, but usually say they would pay 80% in network, they may pay 50% out of network. Medicare Advantage plans have the discretion, as I mentioned, to charge cost sharing above traditional Medicare. We've seen, for instance, in Medicare, there's no co-insurance or deductible for home health services. Some Medicare Advantage plans charge as much as 50% cost sharing for home health services. The only services where Medicare Advantage plans cannot charge cost sharing above traditional Medicare are chemotherapy, renal dialysis, and skilled nursing facility services. And another note of caution, those maximum out-of-pocket costs only apply to Part A and B services, not to prescription drugs and not to any extra services like dental, vision, hearing. Medicare Advantage plans have to offer benefits that are at least equal to traditional Medicare and cover everything traditional Medicare covers. That's what I mentioned at the outset. That is a bedrock of Medicare, that both the public Medicare A and B and Medicare Part C, the private Medicare Advantage plans, have to cover what traditional Medicare offers. Medicare Advantage plans can waive certain restrictions on coverage. For instance, in traditional Medicare, you have to have a 3-day prior hospital stay in order to receive skilled nursing facility coverage. And I would say in most Medicare Advantage plans, they have removed that 3-day prior hospital stay requirement. Medicare Advantage plan benefits, provider networks, and cost sharing can change every year. And that's why I mentioned that it's important to make sure that if the Medicare Advantage plan you choose is not making a lot of changes during the year. And Medicare Advantage plans currently do not provide hospice services, although some may as of 2021. Everyone in Medicare is entitled to hospice coverage, but if someone elects hospice coverage, they have to elect for that coverage in traditional Medicare and not in a Medicare Advantage plan. Medicare Advantage plans do not provide for services related to clinical trials. So again, a summary of choosing between traditional Medicare or Medicare Advantage plan. People have to look at their overall their life circumstances, their health, their need for flexibility and open networks, choice of providers, their budgets, their tolerance for financial risks. I often say when people say, help me figure out how do I choose, it comes down to how well do you want to sleep at night? What's going to help you sleep at best at night? And it often comes down to an analysis of the cost versus the amount of flexibility that someone has to obtain coverage. So finally, I just wanted to provide for you some information about resources that are available through Medicare specifically for hemophilia. There is a national coverage determination for anti-inhibitor coagulant complex. And again, as I mentioned, Medicare Part B covers blood clotting factors and related items for administration of such factors. But this national coverage determination, where I've given you a link here, will provide more information about that. Then there is in the Medicare Benefit Policy Manual, Chapter 6 and Chapter 15, there are more specific rules and regulations regarding, or policies, I should say, not regulations, policies about drugs and biologicals and clotting factors. And here are the links to those resources. Then there is the Medicare Claims Processing Manual. A lot of detail, but again, very specific to hemophilia. And the link to those sections, that squiggly kind of thing in front of the 40, the 80, and the 90 is, it's the symbol for section. So the section of Chapter 17, which I've given as a link here. And then there are Learning Network articles. They're not articles like we think of articles. I don't know why they call them articles. They are actually instructions to the Medicare contractors, it's called the Medicare administrative contractors that actually process the claims. And so these are very specific information about those processes. And finally, just to, again, to say thank you very much for allowing me to give you an overview of Medicare. And for any further information, we have a free weekly electronic newsletter. We also have a website with a lot of additional information about Medicare. We have it in such a way that you can search for whatever it is that you're looking for. I would again encourage you to use the state health insurance program resources that are available for individual counseling to help you to determine anything that you want about Medicare, but specifically if you're looking to figure out which Medicare program to be enrolled in. And thank you. Wish you all the best.
Great. So thank you, Kathleen, for that very, very informative presentation. And while this is a pre-recorded presentation, we do have the opportunity to have you guys send in questions. If you have any, you can send them to us directly at advocacy@hemophiliafed.org. And Kathleen, of course, has also volunteered to continue to serve as a resource to our community, and we are happy to say that she will do that. And also, if you have any questions during the virtual symposium, feel free to reach out to the contacts that have been provided. With that, we will end the session here, and thank you for joining us.